The broadcast is now starting. All attendees are in listen-only mode.
Good evening and welcome to tonight's webinar. Tonight we're going to talk about the doctor presentation, the sales presentation, the importance of the doctor's part of the sales cycle. And I just want to have a bit of an understanding as to what that is all about, what the doctor's portion of the sales cycle really means. Well, it sounds to you, well, of course the doctor's portion of the sales cycle. No, the sales cycle actually is initiated by the patient and is propelled by the staff. And the doctor has a small but very, very important portion of the sales cycle.
Well, remember what this season is all about. We started this in July, and we started it as the stairs of the new patient examination, which you're marketing to attract new patients, and of course, the purpose is to get them in, wow them in your practice, and get them to trust you and get them to accept your cases. So there's so many parts of your practice that can either succeed in that or fail in that. So back in July, we started with the new patient calling your office, so that to wow them with a new patient phone call, the doctor calling them prior to the new patient examination, wow them with that, the new patient packet, and the arrival of the new patient for the examination. So we've already covered all those, and now the next thing is, what do we do in that examination? After you've examined and you have the treatment plan in place, how are you going to show the patient, this is what's going on, this is your mouth, this is what you need, this is why, and this is what we can do for you? So there's many ways to do that, and the technology that we found will not only wow the patient, it really opens their eyes, and the responses we get are, oh my goodness, that is I've never seen that before. I've never had this kind of examination before, and I didn't know that. It's amazing what they say to us, and all this brings them through to acceptance of the cases.
But understand, the examination process begins exactly what we talked about: how the phone is handled, how the patient is greeted, the doctor phone call, the welcome to the patient packet, patient coming in, 100% attention from the front desk to that new patient coming in, patient being brought back, dental assistant going over history and also going over all of the things that have already been said on the phone and by the doctor because careful notes were made. So understand, there are many facets of this in order to be able to make this work. The idea is not treatment plan acceptance. The idea is treatment plan acceptance of the treatment that the patient needs. And the way we do that is to make sure that we have differentiated ourselves from every doctor that patient's ever seen. And so far, my part of this has been the doctor phone call. And now my part of this, after the assistant has spent about a half an hour in the operatory with the patient, now my part of this is to do the assessment. That's what I do. The patient has already been advised a little bit about the assessment because our assistants know what is going on in the mouth. I encourage my assistants to treatment plan. I want my assistants to tell me what the treatment is. I don't want the assistants to tell the patient what the treatment is, but I certainly want the assistants to know what the treatment is. That's how they learn. That's how they can provide the patients with everything they need. And rather than my explaining everything, the assistants can explain everything because now they're involved with the patient. Now the 100% responsibility for that patient is the assistants. And I take 100% responsibility too. A lot of us take 100% responsibility. And if we're all thinking about that in those terms, the patient says, oh, wow, everybody cares about me. Everybody understands what's going on with me. Everybody is dedicated to making sure that I get the treatment that needs to be done. If you're marketing directly to patients, you're going to get that debilitated patient who's failed at dentistry. Whether that dentistry was ever done or not, where the patient was so afraid the patient doesn't want to come into the office, the patient is coming in because all of those factors are in place to let that patient know a patient who's failed the dentistry, that this is the right place to go. When you have that patient, then you do a lot of periodontal procedures, then you do a lot of dental implants, you do a lot of surgery, you do a lot of extractions. And you can make friends with your prosthetic dentist because you're providing a lot of prosthetics to him. But the idea is that we're the experts, and we make sure we're trained as the experts, and we make sure that people know that we're the experts, not just by saying it, not just by saying how great we are on our website. No. It's true competence, true predictability, and true care for the patient that's going to bring you to the point where you are the director of dentistry, whether you're the single dentist who's doing it or whether you're going to be running a group. You are the director. That's the whole idea. And so as we go through this, think about, put on a hat, if you haven't put that hat on already, put on that hat of director of dentistry, that essentially you're supervising all of the treatment. That's what the periodontists did years ago. That's what we did. That's been taken away from us. People have chiseled away at us over the past 30 years. Many of you know that. Many of you have been around as long as I have, understand that. Let's reclaim that. We may reclaim that by having a patient seeing us and say, oh, I didn't know you could do that. So let's talk about, I didn't know you could do that. Or more importantly, I didn't know you could be that. So let's look at John. Take a look at John. How long ago do you think John saw a dentist? Take a look at that smile. John doesn't smile this way. John doesn't smile at all. John had to be coaxed and encouraged to open his lips in the form of a smile that he's never done before or hasn't done in years. It was difficult to get this picture. John's a security guard. Okay? Not a high income earner. He's a security guard. Want to describe a little bit more about John?
I do, but I also want to say that John is not someone who was referred over by a dentist. John is somebody who is extremely fearful of dentists because of a childhood experience that he had. And he found us because his desire to have a life that would allow him to smile and laugh and be happy and have relationships, he couldn't do it because of a smile. So what he did was he Googled our name, and the first thing that pops up is Dr. Lee Sheldon, and we have all these amazing reviews. He went through our reviews, and it gave him the confidence to call our office because they were all so great. So it gave him that feeling that, okay, we're safe, we're good, because all these reviews say so. And he called our office, step 1, in your wow factors. Step 2, call our office and get our amazing front desk receptionist to answer the phone and walk him through to scheduling. So when he came in, he was excited to come in. He wasn't as fearful, but he wanted to change his life and he wanted to smile again. So we probably see our new patients faster than any of our members see new patients.
Yeah.
So it's not about all the time that you're spending. It's not about spending hours and hours and hours with these patients. I mean, chair time is money. So it's about how can you wow them, impress them, give them the best care possible in less time to get all your patients in. So for John, he just moved here from New York. He wants to start his life all over again. He's a security guard, doesn't have a whole lot of money, scared to death, but he really has this desire to get this life. So when he came in, like Dr. Sheldon said, he didn't know how to smile. It was so uncomfortable for him. But showing him the technology that Dr. Sheldon is going to show you today made him say, I want this. I don't care how much it is. I will get the money. I want this, and I want it now.
So let's show what John could do with this tool. This tool is called Snap. We find this tool to be very, very helpful, and I'll show you how it works. So essentially what I did was pick the crown and veneers section, and all I'm doing is tracing the inner lips. It'll take me a little while to do that, maybe about a minute. And by the way, the assistants do this in the operatory, not me. I had to learn how to do it in order to be able to show you. So that's what I've been practicing the past few nights in order to be able to do this and do this fluidly and correctly. So let's see how well I do. And it's a fairly simple program. You can see all I'm doing is left clicking, and then I'm dragging, and then I'm left clicking again until we get the lips defined. Now we'll push next, and as simple as that, we get a set of teeth. Now, I'm not sure you like that set of teeth. I'm not sure I like that set of teeth either. So let's go to these teeth. Nah, not that. No, not that. Not that. Maybe that.
Maybe darker.
You want to go darker? All right, let's go a little bit darker.
That's good.
Want to go a little bit yellower? We'll go a little bit yellower. Want to move the upper teeth down a little bit? Move them down a little bit. Don't like the curve of SPI? Let's increase the curve of SPI a little bit. And so we can tailor this smile to John, and you might even do a little bit more. Midline's off a little bit, isn't it? All right, let me move the midline a little bit. Good. Ah, it didn't want to move. There we go. Now let John look at that. And let John appreciate what he could look like. Now, of course, we tell him this is a computer simulation. It's not going to look exactly like this. But it's certainly going to look a lot closer to this than it looks to this. Now what do you think John is going to say next? Well, John now understands what can be done. By the way, we've used computer simulations. We send out the photos to a service, and 3 or 4 days later we get it back. Sometimes you can get it quickly and you pay a little bit more. We've used that. But imagine doing this right in front of the patient. What kind of an impact would that have on you? So let's tell the rest of the story of John. What happened with John?
When he came in that day?
Yeah, that day. And how long did it take for him to accept treatment, which indicates how important follow-up is with a patient. But let's go and kind of put the cart before the horse there.
As we said, he's a security officer. He did not have money. He didn't have much money. He had a desire, a burning desire. And because we took that time to build a relationship and talk with him and show him all this stuff to explain, give him all these options, when we gave him the price, he said, okay, I don't have that money, but I'm going to find that money. And we followed up with him every month for almost a year. And he walked in with the money and said, okay, I'm ready to go, and I want to get this done as soon as possible. He took a loan out with Care Credit and used his Discover card and sold his boat to get the money to do a lower fixed lid prosthetic and an upper full denture.
And this is the result. We don't talk much about befores and afters here. Well, yes, we do. So let's show this after.
Amazing.
Now, that isn't the same smile, is it?
Looks comfortable.
It's a comfortable smile.
Looks natural.
Yeah.
It looks real. He was so excited with this picture. He was fighting back tears here. He was just so thankful, and he was so excited. I mean, I can't. This is a very tough, gruff kind of a guy, and all he wanted to do was give hugs. He was just so excited about his smile. And his goal, he's getting rid of the upper denture, and he's doing fixing on the upper as well. He's ready to go all the way.
Yeah. Now, I want to talk about the importance of this picture, because it's important that every time we come up with a result, and by the way, we should be coming up with a result every single time we see a patient, every single time, that we stop, we appreciate what the patient appreciates, and we take advantage of that by taking a picture of what that patient appreciates. Those who have been members of the AIP for a while know that we do a graduation ceremony for dental implants. We probably ought to do it for perio too. I don't know, we don't. But we do that, and we build up to the point where the patient is willing to wear the T-shirt and smile with us. And of course, these photographs, this series of photographs, is part of a little digital picture frame that just has smiling patient with smiling doctor after smiling patient with smiling doctor. So that the patient who is about to get treatment done is deciding whether or not to get treatment. All he or she sees is smile, 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 smile. I want to be one of those. Smile, smile, smile. Imagine. Happy guy.
Our graduation ceremonies are a lot of fun. There's a lot of laughing going on in there. So when these pictures are showing in that room, there's big smiles, there's big laughters. It shows a whole lot of fun.
So let's show again how this tool can be used, and we'll tell a little bit a different story. And let's take a look at this nice woman right here. This patient had a problem, and she had a problem that had been going on for quite some time, as you can see. And the dentist who participated in the problem maybe didn't restore things as well as he might have been able to. But it was the best he could do at the time, and had sent the patient to me for consultation after this had been done. And teeth started breaking off on the left side. Yes, you know, if you saw the x-rays, you could imagine the reasons why, but just by looking at the occlusion, you can imagine the reasons why. So the patient sent to me, and the patient says, do you notice that when I smile, that my teeth kind of go downhill? Well, I had seen her 3 or 4 months earlier, and I'd noticed it, and I'd brought it up to the general dentist, but yeah. I said, yeah, I did notice that. And the other thing she said was, you know, when I wear my night guard, I feel really comfortable, but when my teeth are together, my jaws don't feel comfortable at all. I really look forward to wearing my night guard. Well, if I showed you a picture of her totally closed, you would see that her nose and her chin are much too close together. In fact, she has a vertical dimension problem, as well as an angulation problem, as well as a dysymmetry, and that's as a result of an accident that occurred when she was 15 years old, and she's an Angles Class 2 anyway, so a lot of things going on here. What could she look like? And so we'll go to the Crowns and Veneers program, just like we did for John, and let's look at what she could look like. So this is an arbitrary vertical dimension of occlusion. It's actually her natural smile. Again, we trace the lips. We don't have to be 100% accurate. We can be close. And we're almost done, coming around the bend. And now push next. And that's all we do is push next. And here's a smile. Now, if I didn't do a thing to that, if I didn't change the curve, if I didn't change anything, can you tell me if the patient thinks that the view on the right side gives her some hope that in fact something can be done? Of course. Now, can we change it a little bit? Of course. We can rotate this a little bit. We can change the teeth until it's something that she likes, although I happen to like that. Okay, we can move to any set of teeth here and give her something that she might like. So let's go back to the original. And that looks pretty good. And we've already showed you with John as the changes that can be made. How many times would you do this with a patient and the patient would say, I want that?
Every time we do this. Every time we do this, a patient can be coming in for an isolated situation in the back and see what we could do for their smile and just say, that's what I want. I've always wanted that. Wow, I didn't know that was even possible.
You're a dentist. You can do this. I'm not saying you should do the crown and bridge. I'm not saying you should do any of that. You can show the patient what he or she can get. Then you have the opportunity of doing the peri. You have the opportunity of doing the implants. You have the opportunity of doing the grafts. You have the opportunity of doing the work that needs to be done. But what you've shown the patient is that you're different, that you can provide that patient with something that patient hasn't been provided with before. That's what you're showing. Now, this dentist who did the work, we love to work with dentists with high integrity. He said, all right, I see where I blew it. I'll credit the patient every bit of money that she paid for the crown and bridge that I did, and I'll redo the case. You think that dentist isn't taking a financial hit? But all the dentist wants is the best for the patient. Part of what we're doing as directors of dentistry is maintaining the ethics of the profession. Part of maintaining the ethics of the profession is doing the right thing. Part of maintaining the ethics of the profession is knowing what the profession can provide, is knowing what periodontists can provide, is knowing that periodontal disease can be controlled, is knowing that teeth don't have to be extracted if they have some periodontitis, that they can be kept, the teeth can be saved. But if they can't be saved, that we have the tools to do the surgical treatment in order to be able to replace these teeth as well. That's part of it. Part of it is a full understanding. And once we have the full understanding, then in fact we can maintain the ethics of the profession and elevate the profession and keep the profession on the highest plane it can. And then you bring the best dentists along with you as you're doing that treatment planning. Whether that dentist works in your office or whether you're working with dentists on the outside, you have the opportunity of working with the best dentist in order to provide the patient with the best result that patient possibly can get. So that's what we're going to do for this patient. We're going to extract all of her teeth. We're going to do the appropriate alveolectomy in order to be able to create enough room for the prosthetic appliances. We're going to do upper and lower implants, and on that same day, we're going to put upper and lower temporary fixed prostheses. And then a few months later, after tissue heals, after everything has come to its final resting position, then we'll make upper and lower zirconia, full zirconia prostheses, and she'll be done. Now, I'm showing you a lot of implants today, and that isn't the point. The point is treatment planning, is understanding, is putting the patient into a position where the patient says, I can see what you can do, and I want that. And that, whether we're talking about isolated perioscopy on tooth number 19 or whether we're talking about full reconstruction, if we can explain to the patient, show the patient exactly what's going on and why it needs to be done through photographs, even through x-rays, then we have the opportunity for the patient to say, oh, I've never been shown that way before. Oh, now I understand how things can be done and how things can be done in order to be able to give me predictable dentistry. And that is what we are selling, folks. We're selling predictable dentistry. And the way we're selling predictable dentistry is by thinking through a case first. And that's what we learned. That's what we learned in case conference. That's what we did every week in school. And that's what we're doing as part of our profession every day. Now, how important is it for you to be able to treatment plan this patient on the same day this patient comes in? Danielle, how important is that?
It's very important because the patient, from the moment they call your office for your appointment, they're ready then. And the faster you can get them in, the higher acceptance rate you're going to have for that. If you let your patient wait more than 2 weeks to come into your new patient examination, one, they may cancel. Two, if they do come in, their chances of accepting is less because they're motivated at the time they call. When they come in, they're motivated. So why stop after the examination and have them come back in a week or 2 weeks or 3 weeks for the price? When they're in, they're ready, they're motivated, they're in the mode to buy. They want the treatment right then. So you start from the beginning to the end, and you don't stop until the patient is scheduled and ready to go.
And this is a sales cycle. It's just the same way as if you were to buy something yourself. You're ready to buy something. If somebody put you off, you'd either say, all right, something else is going to come into my life and I'm going to have to spend the money there. Or I'll buy it from someone else. Now, I hate to be crass. We are doctors. But understand, in any particular position, there are times when people are ready to make a move and times when people aren't. There are times when you're ready to buy a new suit and maybe buy 1, 2, or 3, and when you aren't. There are times when you decide, I want to buy jewelry, and you're ready to do it now, and sometimes you aren't. Same thing with us. It isn't crass, it isn't crude to be able to give patients the best dentistry they possibly can. that we possibly can, and to provide them predictability so they're not going to have the dentistry redone. That's a service that we as periodontists can provide. That's a service that you as a periodontist can provide, even if you're not going to do the whole thing. The idea is you're the director of dentistry. You're directing how this dentistry is going to be done. You're directing the order of treatment. Of course, you'll do it in consultation with the general dentist, but you'll get 90% of it yourself. The general dentist might say, well, I'd rather do this first rather than that first. All right, you iron out those details later on. It's treatment acceptance first, and then do the entire roadmap afterwards. And it can be done. We've been doing it. I've been doing it for years. You can do it. Are some mistakes made? Yeah, occasionally. But they're minor mistakes. They're not major mistakes. They're mistakes that can be ironed out between you and the general dentist. The patient doesn't even have to be involved in it. The ultimate result is what's important. The patient has to be involved in if major changes have to be made in the treatment. I'm talking about if there are changes in the order or something like that. That isn't something the patient needs to be involved in. It's just saying we're going to do this first, we're going to do this second, and here's the result. It's the result that the patient's looking for.
This is the reason why direct-to-patient marketing is so important. You don't have to do any of that. Patient comes in, they haven't seen a dentist in a long time, ever. They've been waiting to do something for a long time. They go straight to you first, and then you can send them to the dentist that you love to work with, and you can plan the case as big as you want. So very important. But the technology that we use during our new patient examinations, whether it's the SNAP program, the CAT scan program, the in vivo program, this technology says that there's no question that we can deliver success. And that's what patients are thinking when they're looking at this. And he's saying, here's your sinus, here's your bone defect, here is this, here is that, here's what I'm going to do to avoid this and do this, save you money here, save you money there, save you some treatment here. So he's telling the patient right then, this is what it is. This is what I'm going to do, and they're sold.
So let's look at another way, and let's look at something else, and let's look at the CT scan. And let's look at this woman. You don't have the photographs here. I won't show you the photographs. But the patient is concerned that she's got recession. She's got gum recession. You took a CT scan for gum recession? You're darn right I did. We're talking about a three-dimensional problem here. If it's a three-dimensional problem, I have the ability to look at this three-dimensional problem and assess it for myself and help the patient assess it as well. Why am I getting recession? It's not a lack of attachment, but that's not it. That's not the reason. Let's take a look as we go from the interproximal site between 22 and 23, and now let's go to tooth number 23. The problem is tooth number 23 is wider than the bone. You see that? And so when the tooth is wider than the bone, the tooth has a very thin layer of bone right here. And what's going to happen? Well, that bone is gradually going to go away. It's not getting a blood supply. And so is the tissue, because the bone holds the tissue up. Got a size 8 tooth, we got a size 4 bone. Let's go into proximally and appreciate that again. So now we go to tooth number 24. Shows up exactly the same way, maybe a little bit worse. We'll cross the midline. Now we'll go to number 25. Here's the lip. Now we're on that side. We'll go to 26. Look at that. 26 is wider than the alveolar housing. And let's look at number 27. That's even worse. And we go to 28. That's almost as bad as 27. Now we go to 29, and we're getting closer, but it's still sticking out beyond the confines of the bone. And now we go to 30, and finally 30 is within the bony housing. Even if the patient only has recession numbers 24 and 25, we know that this patient is going to get recession through number 29 on one side and through number 20 on the other side. We know that we can't stop the graft in one particular point. And now the patient understands it as well, because she sees how the bone deficiency goes from bicuspid to bicuspid. So it doesn't make any difference what graft you like to do the best. Okay, whether it's a subepithelial connective tissue graft, whether you like to do pinhole graft, whether you want to do a bone graft in order to build that area out, however you feel is the best way to do it, now the patient sees the reason that it needs to be done. But now let's go to the anatomage program and see what that looks like. And so when we look at the anatomage program, we see this view, but let's take a look at the bone view. Do I need to describe to you what's going on here? More importantly, do I need to describe to the patient what's going on here? The patient can see the root prominence. The patient can see this deficiency in bone. The patient can see that once we get to the molars are covered by bone. The patient can see that the upper teeth are covered by bone as well, and that's why she doesn't have any recession there. It doesn't take a lot of explanation. It takes visualization. And it gives me an opportunity to decide if I want to do a bone graft here, what I have to do in order to be able to fill this in properly. If I'm using PRGF and cortical-cancellous bone, I know what I need to do in order to be able to create the environment for success. If I decide to use a more conservative technique, whether it's a tunneling procedure or a pinhole graft procedure, I know what I can expect, and I also know where the deficiencies are in that technique for me, and have a better opportunity of understanding what the best way is for me to be able to treat that patient. This isn't just a sales tool. This is a diagnostic tool. Diagnostic tool for both the patient, diagnostic tool for me, in order to be able to determine what the patient needs and what the patient's going to benefit from and what's going to be most predictable for the patient. See that? Now you're saying I don't have a CT scan. I can't afford $135,000 for a CT scan. What do I do? And the answer is you do the same thing that we do. The only difference is that you ask the CT scan truck to come to your office and take the CT scan. Or you send it out to a dentist who happens to have a CT scan. You get the DICOM files. You buy the anatomage software, which when I bought it cost around $5,000. That time it came with 20 free surgical guides. I don't know what they charge now. But whatever it is, you do that. Well, a patient can't afford $300 for a CT scan. You're right. The $300 ruins the sales cycle. The patient now has to hesitate and say, well, do I really, I've already spent money for the examination. Now do I want to spend money for the CT scan too? We don't want that patient to go through that hesitation. There's no reason for that hesitation. Patients don't pay for diagnosis in the dental office. They don't. They do in the physician's office, but not in our offices. Patients pay for treatment. And perhaps the only way that this patient is going to pay for treatment is if the patient could see this. So maybe you can't afford $135,000 for a CT scan, but you can afford $300 and give the patient the CT scan for nothing, and you pay for the CT scan yourself. You can do that. As a matter of fact, if you talk to one of those mobile trucks and you say, listen, I'm going to have all my CT scans, I'm going to pay for them myself, what kind of a deal can you give me? Maybe you can get it down to $250. Maybe you can get it down to $200 per CT scan in volume. Maybe while that truck is there, you have 3 or 4 patients lined up, so that truck doesn't have to move from office to office. That patient or that truck is actually seeing multiple patients at one time. And then you take the DICOM files, as I said, you put them on your computer, and now you can do exactly this. I encourage you to do that. As with any program, we pilot it out. We do a pilot first and see how it works. And if we do this properly, don't you think the opportunity of acceptance of treatment is going to go higher because the patient can now see what the problem is? Isn't that worth a $300 investment to allow the patient to see that? And perhaps get treatment done, which will save that patient from root sensitivity and save that patient from an aesthetic problem, if in fact those lower teeth show, or if it occurs in the upper teeth, where the upper teeth show. It's not our opportunity to be able to help a patient make the right decision. This tool can do that. Let's take a look at something else. Patient comes in, she has a very loose tooth. You'll see it in a moment. You'll see why it is loose. And we'll have a better understanding as to what we can do with CT scan software to actually save a patient money. Yeah, save a patient money. Amazing. So let me start from scratch. Move this down a little bit. Okay. So this tooth is badly periodontally involved. You may not be able to see it as well. You'll see it better in a second. Well, I'll tell you what. Let me show it to you right now. So let's take a look at this tooth. You see how it's badly periodontally involved? Yes, I had a root canal done. I'll show you the bone view. Okay. So you can see this tooth is going to come out, right? You can also see that there's a nice septum of bone right here. I'll show you how we use that in a second. You already know how you use it physically, but let's put an implant in the number 20 site. Understand now we can use that septum of bone and put the implant in place in that septum. I'm going to go back to the teeth view, and we're going to move this tooth over a little bit, or this implant over a little bit, and show where that implant can go. Now we can take advantage of this bone, place this implant here, and the implant will fit within the bone. Let's get it within the bone right here. Missed that. Let's make sure that's there. Okay, so now the implant can go in this spot. We've got plenty of room for that implant. But can you see where when I extract your tooth, there's going to be an open socket there. So I'm going to have to put a bone graft in this area here in order to make sure that the distal aspect of this, and I'm not going to say distal, but this aspect of the implant is going to be covered because that socket is going to be open. Can you see that? Most will be able to see that. Well, I was told I need two implants because it's matching against two teeth. Well, maybe you do, but maybe you don't. Let's put a restoration on this implant and see what happens. Oh, and we'll shorten this crown a little bit. By the way, this takes some practice. You're not going to learn it all at once, but it's certainly worth practicing on. Because if I open it up like this, now with one implant and I put in kind of a molar tooth on that implant, we can engage both of those upper bicuspids just fine. And we can do this with only one implant rather than two. How do you think the patient feels when we tell the patient, we can save you money? You only need one implant rather than two. That patient, that makes a difference to that patient? Of course it does.
They're very impressed by what you can see that they never even knew was a reason why something had to be done. And you're showing them in this colorful skull image of theirs, and they're just so impressed that you can see this, and you know this, and you're talking in confidence, and you're talking in saving the money. They're very impressed.
So that's what you can do with this particular program, and so the Anatomage program to me is essential. You know, patients are so impressed. I'm in the operatory and I'm doing their surgery, and that's what the assistant says. He's doing your surgery right now, and they look in amazement as I'm putting the implants in and we're putting the teeth in. Let's show another way in which this program can be used. Now, this patient came into me. Again, you're going to see as you start advertising for these kinds of patients, you're not going to see the traditional periodontal patient who has 7mm pockets or the patient who needs the isolated graft. Although you get some of those, we get a number of periodontal patients come in. Actually, Our periodontal patients and the scope of the periodontitis that the patient has that walks into our office now is far greater than the scope of the periodontitis we had when a patient was referred. Referred patients are in the system. They're getting their teeth cleaned, that type of thing. And so things are relatively well under control. Things go awry, and that's why patients need us. But patients like this,
They haven't seen a long time.
not a long time. You're right. They just haven't seen anybody. And so they've got problems. So this patient, without going into detail in the x-rays, I'll show you the bone view, but you'll see that there's an awful lot. I'll brighten this up a little bit so it's not too exaggerated. This patient is a class 2 malocclusion. The patient is going to lose all of his teeth. And so the patient's coming into me because the patient needs an expert, is without dental care, and of course, with the public relations, the marketing that we do, we're perceived as experts. That's what we're teaching you to do as well. Excuse me. But here's what a patient doesn't see. Patient doesn't see this. Let's brighten that up a little bit. Let me change the position of the section just a little bit. Yep, that's good. Now, this doesn't show up as an exostosis in the patient's mouth. Soft tissue is pretty thick here. But what would happen if a denture went over this area? What do you think would happen to that patient? Number one, the tongue is already constricted. Can you imagine just having thicker acrylic in this area and having the tongue constricted even more? But it'll be worse than that, because what happens when the flange is going to rub up against this? And that's what I tell the patient. What happens when the plastic of the denture is going to rub up against this? See how sharp this is? That's going to produce a sore spot, and there's nothing we can do about that. Oh, we can relieve the denture. So you won't have the sore spot here, you'll have the sore spot here instead. So now the patient understands the reason for treatment, understands that exostosis removal needs to be done as part of the extraction procedure. I think if you put your finger against the area, particularly if there are no tori there, I'm not sure that we can communicate that nearly as well as we can communicate this. So that's the importance. That's the importance of a patient being able to visualize. You want to visualize things too. You want to know what you're going to look like, or whatever you're going to buy, whether it's an architectural rendering, you see what the new house, the new building is going to look like, what the new roof is going to look like, what the new car is going to look like. Look like, look like, look like. Patient can see this. A lot more to this than just words. Patient can see this. And then we'll understand there's a reason for the extra fee, because exostosis removal is going to make that patient more comfortable. That's how we use these tools. That's how we use these tools in the operatory. And then the patient goes back with our financial assistance and spends usually a full hour after I've given options, showing the patient what's going to be done. And then the patient understands what needs to be done and can make a decision on what he or she wants to do. Even if I've given them more than one option, the financial assistant has given them options as well, has explained, has shown models of what each option means. We have books of successful results so the patients can see on photographs what can be done. And then the patient can make an appropriate decision. It takes work. It really does. It takes time. If we're going to develop our practices, we need to be able to develop the tools in order to be able to create an environment where a patient can say yes. And these are a couple of tools that allow us to do that.
Yes. Now, on this one, I was going to show you, though, for a patient that comes in, and I hear this all the time, a patient will come here either on a second opinion or a patient will come here and think that they need just a few extractions and a denture. You show them this, and there's no question about what he is planning. It's there, it's clear, it's their bone, it's their anatomy, and they are not only impressed that it's found, they understand every extra expense to get them to the treatment that is best for them. There's no question of, well, the other guy didn't say that, and why are yours so much more expensive? You're showing them why and what you have to do, so it takes that out of the equation.
So I hope you get the idea of how these tools can be used. Next week, well, a lot of things that are happening. But next week, we will meet again next Wednesday night, November 18th. That'll be our question and answer session. Email us your questions, and that's where we get our questions from for the questions and answer session. So thanks for sending the emails. And of course, we want your live participation as well. Perio meeting is this weekend. So Sunday night, November 15th, we will be at the Palm Beach room of the Gaylord Palms, and we'll be giving a presentation for prospective members at 6:30, and our member mingle will be at 8 p.m. in the Palm Beach room. I haven't met a lot of you, and I look forward to meeting you in person. That's it for this edition of our AAIP webinar. Hope you enjoyed it. Hope you have some real good tools. Have a great week, and if you're at the meeting, I really look forward to seeing you. Danielle looks forward to seeing you as well. Have a good night. Thanks for joining us. Good night.